get rid of the clicker before I drop it. Thank you, Madam Chairman. Susie, I appreciate the opportunity to bring forward, this is House Bill 1097, and I want to thank Representative Kirchhofer, Representative Lindar, and Representative Austin as being my co-authors. I'm going to give you a little bit of a rundown of each section of the bill, if you've seen it. Section 1 removes the language that references the Practice Act requirement for advanced practice registered nurses in a section of code which allows the APRN to serve as an eligible provider for the supervision of a plan of treatment for the patient's outpatient or substance abuse services. This section of the code only applies to community health centers and does not impact the ability of the APRN to continue to serve in that role as the eligible provider for the supervision of the plan of treatment. It's cleaning up the reference of the to be consistent with the remainder of the bill. Section 2, the code adds APRNs to the list of practitioners, current list of practitioners that can sign a practice agreement with an APRN. Current law only allows the following: a physician, a dentist, a podiatrist, or an optometrist to do so. So this would allow an advanced practice nurse who has the to be one of the on that list. It requires an APRN to operate with a licensed practitioner as evidenced by a practice agreement, by practice granted by the governing board of the hospital, by privileges granted by the governing board of a hospital licensed under IC 16-21 with the advice of the medical staff of the hospital, and sets forth the manner in which an APRN cooperates, coordinates, and consults with other practitioners in the provision of the hospital care to their patients. This is current language in the statute, and the bill changes the list of practitioners as we listed the bill for that reason. Or the privileges granted by the governing body of the hospital operated under those numbers that were set forth in the manner in which the APRN will work in the provision of health care for their patients. It's incurred language in statute. The bill changes the list of practitioners as included in the bill for this reason. It requires the APRN with prescriptive authority to operate without a practice agreement in the following, if the following conditions are met. The APRN has operated under a practice agreement with a practitioner for at least 1 year. The practitioner signing the practice agreement has been licensed in Indiana for a minimum of 5 years with the practitioner's respective governing board. And this would include the nurse practitioner, APRN practitioner that we're adding. They would still have to be practicing with that for at least 5 years. The practitioner has reviewed at least 5% of the APRN's prescriptive charts during the practice agreement period, and the APRN has submitted an attestation to the board to the completion of the required 1-year practice agreement. It requires the Indiana Professional Licensing Board, State Board of Nursing, to include an I under the prescriptive authority license number to indicate the advanced practice registered nurse has completed the requirements under this legislation. This is so to make it easier for the hospitals to find out if the advanced practice nurse has been doing so. We do have a little bit of an issue with that. I've talked to PLA, and they are not sure of the technical issues involved in doing that, but we are working through that, and I'm sure we'll have a good agreement with them in one way or another that we can get that done. So I've talked to them at that. This is what the bill does. I want to thank you for listening to it, and I'll try to answer any questions that you have.
Thank you, Representative Bacon. Before I open up for questions for you, my goal is to limit testimony to an hour, 30 minutes to each side. Hopefully we can get it done within that time frame, a shorter time frame. And we considered, or you requested, a video to be played. We're going to withdraw that request. Okay.
That's why I didn't respond to your, I'm sorry.
Thank you.
Should have said,
Okie doke. All right. Well, any questions for Representative Bacon before we move to testimony? Okay. Seeing none, thank you. First up would be Angela Thompson, Doctorate of Nursing Practice, and Heather Willey, representing CAPNY, and Julie Haubig from Hospital Association. If you'd be on deck, please.
Thank you, Madam Chair and members of the committee. Heather Willey here today on behalf of the Coalition of Advanced Practice Nurses, as well as the Indiana Council of Community Mental Health Centers. I rise in support of House Bill 1097, and I want to thank Representative Bacon for all of his efforts so far on this bill, and I know we'll have more work and dialogue to come. I also want to thank you, Representative Kirchhofer, for also signing on to the bill and being a good part of the discussions really now over the last 3 years that we've been talking about this issue. Also to you, Representative Lindauer, for joining the bill, and Representative Austin as well. Before I turn it over to Angie Thompson, who's our Director of Health Policy for CAPNY, I just wanted to make a couple of other quick remarks. We have been talking about this now for a couple of years, and while we haven't had the opportunity to find agreement with the physician community, we have had a lot of good conversation and dialogue, and in the introduced bill that you have before you, we've tried to make some concessions based on some of the comments we've heard in years past. I specifically wanted to call out and thank Dr. Feldman, who works with the Indiana Academy of Family Physicians, who sat through many meetings with us, and we appreciate that, as well as Dr. Wink and Dr. Tharp, who represent Indiana State Medical Association, who've also started some good dialogue with them this session. So while we haven't found agreement yet, we do appreciate having these ongoing dialogues, because I think ultimately it'll make it a better bill in the end. And with that, I'd just like to turn it over to Angie for some comments.
My comments are 3 pages, but I think that's pretty good because I started with 11. I'll do my best to be brief, but I want to be thorough as well. So as Heather Willie indicated, I'm Angie Thompson, and I am the current Legislative Director for the Coalition of Advanced Practice Nurses of Indiana, or CAPNY. I am a nurse practitioner. I'm board certified as a family nurse practitioner, and I practice in Hendricks County at Hendricks Regional Health. And I have been a registered nurse for, I think this year it'll be 25 years, and I've been a nurse practitioner since 2009, I believe. And I'm joined by many of my nursing colleagues and APRN colleagues in the audience, and I know many of them got an opportunity to meet with a lot of their legislators and that are in this room over this particular topic this summer as well as this fall. So I just wanted to recognize them for that. APRNs have been practicing for over 50 years, and in Indiana specifically since 1993, they've had prescriptive authority. And prescriptive authority requires that an APRN has a practice agreement with a practitioner, and that practitioner can be a physician, it can be a podiatrist, it can be a dentist, or it could be an optometrist. And that just allows for a little bit more flexibility, especially in those rural areas where there may not be a practitioner that's a physician to be able to meet that requirement. The practice agreement requires as well in statute that the practitioner that is the part of the APRN practice agreement retrospectively reviews 5% of the APRN's charts. But it doesn't necessarily require comment, signature, just a retrospective review. House Bill 1097 would allow APRNs to prescribe without having to have a practice agreement after certain conditions are met and after a year of having a practice agreement. The reason why it's so important to remove this regulatory burden is that there's a lot of difficulty with APRNs, especially in underserved counties and rural areas of Indiana, in trying to find a practitioner to meet this particular requirement. And so there's a lot of counties that actually don't have any primary health care available to them or any provider that's available to be able to provide care. Removing scope of practice arrangements, agreements, restrictions is actually endorsed by many organizations, the Federal Trade Commission, the National Governors Association, AARP, the American Enterprise Institute, the American Hospital Association, Robert Wood Johnson Foundation, the National Conference of State Legislators, the National Council of State Boards of Nursing, and most recently the Heritage Foundation. And in 2016, the Veterans Administration, which is one of the largest integrated healthcare systems, removed the practice agreement requirement for their APRNs. And that's really in line with the military health services as well as the Indian health services policies and practices. So as I indicated, a lot of organizations and even other states are removing this restriction, and it's primarily because it creates a lot of barrier to getting access to care. APRNs, as I indicated, are often having a very difficult time finding a provider to meet this practice agreement. And House Bill 1097 would really make a huge difference by allowing APRNs to practice without this agreement and provide much needed health care. That's been supported by a 2017 RAND analysis. CAPNY commissioned the RAND Corporation to look at access here in Indiana, and if scope of practice regulations were removed, just what would that look like here? And what they found was that specific to primary care services, it would actually allow more access to over 379,000 Hoosiers who would otherwise forego care. This study also showed, or this analysis also showed, that ER visits would be reduced by up to 14%, and that it would increase well child care access by up to 32%. And that analysis really correlates with a lot of the national data from the last 2 decades that, in the most recent analysis in November by the American Enterprise Institute, that showed that 63% of people living in non-restrictive states have greater geographic access to primary care providers compared to 34% of people living in states that have restrictive scope of practice regulations. Additionally, states with restricted practice have 40% fewer APRNs in compared to those who do not. And the results from this study have also been shown very similar in other states who have retired their scope of practice regulations, like Arizona. Arizona showed an increase by 52% in APRNs practicing not only in their state, but also migrating towards rural areas. Nevada showed a 33% increase after just 3 years of full practice. North Dakota reported an increase of over 80% after 5 years of retiring this restriction. And in Indiana specifically, the RAND Corporation estimated that our APRN workforce would increase by as much as 46% after 1 to 2 years of removing scope of practice regulations. So I want to just reiterate as well that if this practice agreement of House Bill 1097 is enacted, it in no way will jeopardize the safety of Hoosiers. I think that's really important to understand. There's over 50 years of research that indicates that the quality and safety of APRN care is comparable to other healthcare professionals like our physician colleagues, and that prescribing practices, referrals, ordering, and imaging studies is very comparable and similar across healthcare professions. There's also no evidence to support that independent prescribing practices will increase the number of prescriptions written that have abuse potential. And I think that's really important with the epidemic we have in regard to opioid abuse nationally and in our state. This is true also when looking at retail prescription data. There was a published report in 2016 that indicated that those states who have non-independent APRN prescribing laws actually had significantly higher opioid and benzodiazepine prescriptions in comparison to states that had APRN prescribing laws that did not require this practice agreement or did not have scope of practice regulation. There's also no evidence to date that state-level scope of practice restrictions protect the public from subpar health care. Each APRN is really accountable for the care that they provide to their patients. They're accountable for the care they provide to their nursing profession and to the licensing board, as well as complying with requirements of the State Nurse Practice Act and the quality of the advanced practice care rendered. It's important to recognize that APRNs, it's up to them to know the limits of their knowledge and expertise and ensure that they're planning for the management of these situations that could possibly be beyond the APRN expertise. They're also responsible for consulting and referring patients to other healthcare providers as appropriate. Additionally, the Federal Drug Enforcement Agency licensure and the State Department of Consumer Protection Drug Division has jurisdiction over APRN license to prescribe controlled substances. Retiring the practice agreement also would not in any way impede collaboration among professionals. The nature of healthcare professionals is inherently collaborative in this standard feature of patient care. Communication and referrals occur between appropriate clinicians at times based on their clinical judgment, not because there are actual legal mandates to do so. Removal of the practice agreement will also not change the scope of practice for APRNs. It merely allows APRNs to practice to the full scope of their education and training. Under Indiana Code, APRNs are defined as individuals who make independent decisions about the nursing needs of clients. APRNs provide primary care services, and primary care comprises a broad range of services, including evaluating new symptoms, as well as ongoing care for chronic diseases, preventative health services like immunizations or screenings, and these just so happen to overlap and complement those of our physician colleagues. APRNs are not prepared to provide all healthcare services to all people, nor do they aspire to. House Bill 1097 only seeks to remove this regulatory barrier that hampers the ability to provide the care that falls within the APRN current scope of practice. Indiana is facing many challenges with providing adequate health care, and during this time, it's critically important that individual healthcare organizations and professions make it a high priority to evaluate ways to enhance and not further restrict access to health care. Actions to marginalize other healthcare professions do not achieve this objective and ultimately fail patients who should be our main focus and priority. APRNs in the nursing community would like to work in partnership, not in opposition, with our professional colleagues to address these healthcare needs of our patients. So in summary, I think it's time to move forward with these proven solutions and retire outdated regulations so that we can better meet the state's current and future healthcare needs. 22 states already allow APRNs this freedom to put their education training to work to improve the health and the lives of residents, and Indiana should really do so as well. So on behalf of the patients in Indiana and CAPNY membership, I urge you to vote in support of House Bill 1097. And with that, I will open up for questions. And I
Thank you, Nurse Thompson. Given that I've imposed time restrictions, if you'll stay close by, I'm going to continue with testimony and then let the committee members request who they'd like to question. Certainly. And we'll keep it on track that way. So if you'll stay close by, you're welcome. Julie Halbig with the Hospital Association and Lacey Hamilton, if you'll be close by on deck.
Thank you, Madam Chair, members of the committee. Julie Halbig here on behalf of Indiana Hospital Association's 170 members representing private, public, acute, and specialty member hospitals. As you can imagine, advanced practice nurses are a huge critical part of our workforce in providing care for our patients. We employ thousands of them across the state, and especially for our rural hospitals, they provide a critical gap in providing access, as Angie mentioned in her testimony. We most definitely support a phase out of the collaborative practice agreement. We have had discussions internally within our membership as well as with CAPNY, and specifically want to thank Heather for her countless time that she's given in answering our questions. I think two things just want to bring attention to. We are committed to trying and get this bill across the finish line this year and very much want to do so. I think we would prefer a slightly longer transition time, more than a year. And we're glad that we're going to be able to work with the bill author and others and CAPME on maybe what that sweet spot is. Let's face it, medicine has gotten more complicated, technology and et cetera, and we'd like to see a slightly longer time on that. The only other thing I think we would just potentially like to discuss further is on page 3 of the bill, on D2 there, I think we'd feel a little bit more comfortable if before we phase out the collaborative practice agreement, we'd rather that be done physician to APRN instead of APRN working under a fellow APRN. There may be a way to kind of split that in the middle, if you will. If it's a physician with 5 years experience, but an APRN collaborating or having a partnership agreement with another APRN, maybe just adding some additional years of experience while in practice. So happy to keep continuing those discussions. But I think a lot of our questions from last year were addressed by some of the measures that we added in last year's bill, specifically related to the different tracks that APRNs now choose, and the fact that they're accredited, additional, obviously, coursework, continuing ed, and then as it relates to the prescriptive authority, we have multiple checks and balances there, both from InSpect, the bill that we passed a few years ago on the 7-day supply when first prescribing an opioid. So I think a lot of those kind of checks and balances there to make sure that we have safe prescribing practices are in place as well. So appreciate all the questions and answers that CAPME provided to us. Happy to answer any questions.
Thank you. We will move on and save questions for later. Lacey Hamilton and then Amber Marr, if you'll be close by.
Good afternoon. Thank you, Madam Chair and members of the committee for the opportunity to provide testimony today. My name is Lacey Hamilton. I'm a family nurse practitioner graduating from IU School of Nursing. I have been a nurse practitioner for 6 years, practicing solely in community health. Currently, I'm the Chief Clinical Officer for Riggs Community Health Center, where I oversee all care given by the nurse practitioners while keeping my practice inpatient care 2 full days per week. Riggs Community Health Center is a federally qualified health center in Lafayette, Indiana, caring for the underserved population in this region. We currently have 1 medical doctor per 6 NPs in all departments across 4 sites. Becoming a nurse practitioner-led clinic on a larger scale has contributed to improved patient access, increased quality scores, as well as abundant financial security at this organization. With this NP-led model, Riggs has been able to advance to roughly 250 days cash on hand from 60 days previously. This has been accomplished through an increase in patient visits by 33% in the last 4 years, placing us at 60,000 visits for 2018 across all ages. Specifically, over 7,000 children and 1,300 pregnant women were seen last year while servicing 60 walk-ins daily, creating open access. We are fortunate to be able to spend approximately 30 minutes with each patient, collaborating with our NP and MD colleagues to give safe, excellent care. In 2018, Riggs received our first substantial quality award from MDWise, one of only 16 recipients in the state. A new preceptor model for NP students has been developed by my colleague, Dr. McQuaid Jones, along with Indiana University and Purdue University nurse practitioner programs, allowing 2 NP students to every 1 preceptor. Embracing this model has enabled Riggs to educate 15 NPs each semester and many times employ those individuals directly. Currently, there are 234 nurse practitioners serving as primary care providers in our FQHCs across Indiana. One can see the great impact this model of care can have widely across the state and country. On behalf of nurse practitioners serving some of the most vulnerable populations in Indiana, we urge your support of House Bill 1097. Thank you.
Thank you, Nurse Hamilton. Amber Marr, and then Mary Browning, if you'll come close.
Thank you, Madam Chair. I actually have a couple of folders. Do you want me to hand them out
Sure,
at the end
yes.
or now?
Why don't you go ahead and provide your testimony, and
Great.
then you can.
That sounds perfect. Thank you, Madam Chair and members of the committee. Amber Marr, representing AARP Indiana. With approximately 835,000 members statewide, we appreciate the opportunity to rise in support of House Bill 1097 today. As our population ages, it is imperative that we explore additional ways to deliver access to reliable and quality health care for Hoosiers and their families. Increasing access to care matters to everyone in our state, but especially it matters to nearly 840,000 Hoosiers who serve as family caregivers. Family caregivers are the backbone of our long-term care system here in Indiana, providing care valued at $9.5 billion annually. Most of us have been, or will be a family caregiver. Current restrictions on advanced practice registered nurses add to an already challenging situation that not only hurts patients but places added stress on family caregivers who are often already overwhelmed due to juggling work, their caregiving role, and other family duties. By allowing APRNs to practice to the full extent of their certified skills, more Hoosiers would have a choice of local care that they could access where and when they need it. In rural communities and other underserved areas, it's already difficult enough to access care. But in states that have given full practice authority, APRN growth rates have increased, with the largest increases happening in rural areas. House Bill 1097 removes bureaucratic red tape that can prevent APRNs from serving as primary care providers and working to the full extent of their license. A survey of Hoosier voters age 45 and older, conducted by AARP in 2018, showed that 86% support allowing APRNs to serve as the primary or acute care provider of record for a patient, and that information will be in the packet that I hand out. Indiana has the opportunity to join 22 other states that have revised overregulated health rules, giving all Hoosiers access to high-quality advanced practice registered nurses for the health care they want and deserve. We want to thank Representative Bacon for bringing this bill forward, as well as the numerous other individuals that have signed on thus far. We also wanted to thank Representative Kirkhofer for hearing it, and we respectfully ask for your support. Thank you.
Thank you, Ms. Marr. Ms. Browning? And then Robin Newhouse. There are 3 of you left, and we've got about 10 minutes. So if you agree with something, try to keep that succinct. Thank you.
Thank you for the opportunity. IONE, the Indiana Organization of Nurse Executives, rises in support of this House Bill 1097. We represent nurse leadership across the care continuum in the state of Indiana, including hospitals, long-term care, ambulatory care, and education. We believe that Hoosiers deserve high-quality patient care, in particular, access to high-quality patient care. That is one of our goals, and we highly support and encourage you to vote positive on this bill. Thank you, Representative Bacon and Representative Kirkhofer. This is extremely important for us to continue down the road of having a healthy Indiana. Thank you.
Thank you. Ms. Newhouse, and then Kathy Williams, you'll be the last to provide support.
Hello, I'm Robin Newhouse, Dean of Indiana University School of Nursing, although I am not representing that capacity. I'm testifying on behalf of myself. I am a scientist, a registered nurse in Indiana, and a private citizen. And I feel strongly that this bill will help us advance the health of the people of Indiana. This bill will increase the access to care for the people of Indiana, decrease cost, and will also decrease cost and effort associated with the collaborative agreement processes. 3 points. The quality and safety and effectiveness of advanced practice registered nurses is already established, so we don't have to answer that question. Number 2, we're not early in the game. There are 23 states that have already adapted the practice. And most recently, a prior study in the fall of 2018 was released, and I'd just like to recap a couple of those statistics that haven't been already covered. So first of all, I was principal principal investigator in some of that early work around the comparative effectiveness of advanced practice registered nurses and physician providers and teams. That work was done by an interprofessional team, and I just would like to submit the paper that was published in 2011, which really answered the question about the quality, safety, and effectiveness of advanced practice registered nurses. The design was implemented with a team of interprofessional colleagues that used the methods of the Agency for Healthcare Research and Quality evidence-based practice centers and used the grade system to grade the evidence. So it's there for your review. But just in terms of all advanced practice registered nurses, I'll leave that to the paper. But for nurse practitioners in particular, I'd like to acknowledge that there were 37 studies at the time that were conducted that indicate 37 studies, and then 14 were randomized controlled trials and 23 observational studies. The synthesis of evidence reviewed a number of patient outcomes, including glucose measurement, functional status, health, and perception of health, satisfaction with a provider, and many other things. But the end point in the synthesis was that the quality, the consistency of the evidence was high, which means in the grade system that further research is unlikely to change the confidence of the estimates of effect. So I'll leave that paper for you. The second thing is we're not early in the game. We are in the middle pack. And I'd also like to submit the map of the states that have already adopted the full practice authority, and would say that the VA also has adapted full practice authority for the same reason, based on the same evidence that I'm quoting. The third issue is in September 2018, the American Enterprise Institute published a paper which was a secondary data analysis that looked at a nationwide sample of advanced practice of registered nurses compared with physician colleagues. So our work said there were similar outcomes. But what they found was pretty interesting. Number one, the cost of nurse practitioner provided care ranged between 11 and 29% less than physician care. Second of all, nurse practitioners, although fewer in number than physicians, are more likely to practice in rural areas. That's important for us. Third, people living in states that don't restrict nurse practitioner practice had significantly greater geographic access to primary care. So this was focused on primary care. And then when looking at the analysis of the different classifications that are on this map, there were the states with no restrictions in practice and those that restrict practice, the quality was equivalent. So there is no difference in those states. So in conclusion, I support this House bill because the scientific evidence tells us that it's safe. It increases access and high-quality care to people in their local areas. It's safe, effective, and lower cost. So I'm all for promotion of health for the people of Indiana, particularly given some of the challenges we're facing that Dr. Walthall presented. Thank you.
Thank you, Kathy Williams. And since the chair is fair and there's a late entrant, Blaine Miley will be on deck representing the Nurses Association.
Thank you, Chair Kirchhoff and members of the committee. My name is Kathy Williams. I'm here today on behalf of the Indiana Association of Area Agencies on Aging. I think most of you know that there are 16 area agencies on aging that cover all 92 counties in the state of Indiana, and they are the gateway to services for disabled and older Hoosiers to access services under programs such as the Choice Home Health Services and the Asian Disabled Waiver. The area agencies support House Bill 1097 because they recognize the need to increase access to primary care and medical homes, which you've heard a lot about, especially in rural areas. And by facilitating the practice of APRNs in underserved areas, HB 1097 will help accomplish this goal, and we urge your support. Thank you very much.
It's nice, thank you. Mr. Miley representing State Nurses Association.
Thank you, Madam Chair, members of the committee, and appreciate the chair's indulgence. Blaine Miley with the Indiana State Nurses Association, and on behalf of Indiana's 110,651 registered nurses, we rise in support of House Bill 1097 for the same reasons previously stated by my colleagues. I will simply note that when we say this will reduce costs, specifically one of the reasons it will reduce costs is because that most APRNs have to pay for the collaborative practice agreement, which adds a cost to the healthcare system. And so by removing that, you're going to lower costs down the line for the patients and really going to transform the collaboration that takes place from quantitative to qualitative. So rather than an APRN spending their time to meet a government mandated quota for the collaboration they do, they will be able to really spend their time more efficiently for both the APRN and their collaborator and really focus on those patients that need additional attention. And I also have a letter to submit from Susan Hendricks, who is the Dean of the IU Kokomo School of Nursing and President of the Council of Indiana Nursing Deans and Directors in support. Thank you.
29 minutes, 36 seconds. Okay, that's all those that have signed up to support House Bill 1097. Questions for any of the testimony individuals here? The two physicians, I saw Dr. Fleming's hand first and then Dr. Barrett.
Okay. I've never been sorry that I was a nurse before I was a physician. I was a nurse practitioner, but 40 years ago you couldn't get a job as a nurse practitioner. I'm very grateful to nurse practitioners. The accessibility, the scope of care as outlined by the speakers has been amazing. My concern is that the only tenuous thread we have of collaboration now is this agreement that currently exists. I think collaboration is essential. I don't want to think it might happen or could happen. In a situation when I was in nurse practitioner clinic in Nashville, we saw kids with rashes, sore throats, and then one day saw a very ill child with epiglottitis, a life-threatening condition. We had an established collaboration with Vanderbilt School Department of Pediatrics that we could immediately get that child to the care that he needed. That is my concern. This isn't perfect. The idea of podiatrist, dentist is kind of ludicrous, but as far as I can tell, and I would like to hear if there's an alternative, this is the only thread of required collaboration that we have.
Thank you. Dr. Barrett?
I have practiced medicine in Indiana since 1988, and for the probably first 4 years of that, I was dependent on a nurse practitioner in that my wife is a nurse practitioner. So I'm very aware of, appreciative of the service they provide and sensitive to that. However, I have some of the same concerns that Dr. Fleming brought up. And I have a couple questions that I've really got to sort out. I'm still kind of struggling with, if one of the practicing nurse practitioners could explain to me how the collaborative agreement, I know it's not really called a collaborative agreement, the practice agreement, could someone explain to the group how that actually works?
I'm not a practicing nurse, someone can talk about it more. I think it's dependent largely. The statutory requirement, which is what we're eliminating in this bill, simply states that there needs to be a practice agreement. When that went into place in 1993, I think it was, there was a rule that was promulgated that gave flavor to what that requirement actually would be. And that rule basically states that if you are an APRN prescriber, that the 5% of your prescriptive charts would need to be reviewed. So I think of it as the current statutory requirement, to make things super simple, is if I'm an APRN and in 1 week I see 100 patients, I write 20 prescriptions for 20 patients. One of those 20 scripts, 5%, would need to be reviewed by a licensed physician, a licensed optometrist, a licensed dentist, or a licensed podiatrist. The State Board of Nursing has on their website a sample practice agreement to give flavor to folks who are trying to, work with practitioners to meet this requirement. And there's language in there that's not statutorily or rule driven that says things like, you should be available for consultation to the prescribing APRN. My guess is if when we keep the language with the transition to practice period, that would remain as a template for folks to use. I think, in practice, there is a lot of collaboration that does take place, as Angie mentioned. And I also think it's important that there's nothing in this bill that would restrict or prohibit an employer-employee relationship from imposing additional restrictions. For example, if you are in a hospital setting and you're the medical director and you're signing the practice agreements for the individual APRNs that work, in the hospital setting, you would still have the ability to say, hey, I want to do a quality review of anyone, writing a controlled substance script. So I want to look at my prescribers and their prescribing practices to determine if I believe, we're prescribing at the right rate. Or if you were in an individual physician's office, for example, and you wanted, as you were saying, working with APRNs to require review, you certainly have that right as an employer. So we're not doing anything to work to restrict the employer-employee relationship as well. Does that answer your question, Dr. Barrett?
I was looking more for in actual practice, not the theory of it. If one of the nurses practitioners could speak to how it works in their practice, but I could get that information.
Yeah, we've had lots and lots of dialogue with members. Angie could probably add flavor to that too. I think it really depends. It depends on the individuals involved in the agreement. So if you're an APRN and you're working in a family medicine practice, you're probably collaborating, talking, with your colleagues all the time. Some have very robust relationships, which I think will continue. Some do not. It's a clearly just a, kind of check the box review of those scripts. So I think it really varies and it's individually specific to the two individuals who are part of the agreement.
I would also appreciate if someone could explain the quantitative clinical hours that go into the training of a nurse practitioner.
Yeah, that would probably, I don't know, Dr. Newhouse, if you want to do that or...
So I would say they vary depending on the type of advanced practice registered nurse. You talk about at least 500 hours, more for family nurse practitioners. If they are earning a doctoral degree, there's at least 1,000 hours. Remembering that these nurses are coming in with nursing practice already. They're already established registered nurses to get into these programs. And then the advanced practice, diagnostic, reasoning, and the treatment of individual patients is covered under the APRN curriculum. So it ranges.
I think I'd heard the number 15 40-hour weeks go into that. Can anybody confirm that?
Let's see, 15 40-hour weeks. The programs vary in the number of credits that they have, and they are guided by standards from the professional organizations. So the curriculum itself is guided by those standards that are held to be minimal standards for good education. So I can't say I've ever heard 15 times 40.
Do any of our nurse practitioners have that? I was asking about the clinical hours involved in the training.
There's actually a minimum requirement in order to be able to sit for certification. And I believe it's 1,000. Does that sound right? Yeah. Yeah. Yeah, and so and it varies a little bit from the population focus, the family practice versus pediatric versus neonatal. So there is some variation, but the statute specifically addresses, the Indiana State Board of Nursing governs and ensures that here in Indiana, as well as in other states, their Board of Nursing governs not only the curriculum, but the hours and the criteria. so that they are consistent. I hope that answers your question.
I was actually looking for quantitative data because I kind of know what goes into the training of our primary care physicians. And, typically that's 4 years of pre-med, followed by an admission process into medical school, which is frequently not successful, followed by 4 years of medical school, followed by then 3 years of residency for the most part for our primary care providers. And then certainly the more specialized you get, the more that changes. And so, I'm just perceiving a huge difference in the clinical hours of training between these two groups, and that by removing this practice agreement, we are now leveling the playing field, so to speak. And I'm just trying to grasp that in my own mind.
I definitely acknowledge that there's a difference in the training and education. I think we can all agree that there is a difference in the program and the clinical hours between the two professions. However, I think we're losing focus on really the most important aspect of this bill, and that is that there's really the quality of care and the safety of care is equal between the two. So I think we're losing sight of that's really what we need to focus on. And yes, there is an overlap between the professions as far as some of the services that are provided, but there's in no way it's in no way the same for specialists. An APRN is population focused within either family, geriatric, women's health, neonatal, and the entire program is focused on that particular population. We're not performing surgeries. We're not neurologists. We're not. So I think it's very important that we understand that.
Any other questions? Okay, we will begin with those concerned or not in favor. Dr. Stacy Wink from State Medical.
Thank you, Madam Chair and members of the committee. I'm Dr. Stacy Wink, President of the Indiana State Medical Association, which represents over 8,000 physicians across the state, in opposition to House Bill 1097 as written. I'm also speaking as a representative for the Indiana Osteopathics Association, as well as the Indiana Academy of Pediatrics. As a background, I am an internist, a geriatrician, and a pharmacist. As a very brief review of the history of the nurse practitioner profession, this field was developed in 1965, a special year, because that was the year of the implementation of Medicare and Medicaid coverage. With more people having health care coverage, there was a need to support physicians and provide a complementary service for children. This field has grown to include other areas in primary care as well, as you've already heard today. The education for nurse practitioners corresponds to the premise of working collaboratively with physicians to provide care to our patients. Most of you are aware of the differences in the education process, but I'd like to discuss them at a very high level. Dr. Barrett already mentioned physicians complete an undergraduate bachelor degree and then an additional 4 years of medical school. This includes classroom education and regulated clinical experiences, which are tested throughout the educational time. This also includes a series of 3 national exams to ensure competency. Upon completion of medical school, physicians go on to a residency program that requires an additional 3 to 7 years of additional training with regulated metrics and direct physician oversight. Upon completion of this training, physicians then sit again for board exams and certification. This extensive training prepares physicians to provide care to complex patient care needs. The APRN program requires an undergraduate nursing degree. This is not standardized. It can be an LPN, an RN, or a bachelor. Nurse practitioners then go on to complete an additional 2 years of classroom and clinical education. Most of the practicing nurse practitioners offer a master's degree that's 89.4% upon completion of the education. And there are a small number of doctorates in nurse practitioner, that's about 6%. The clinical hours have requirements for completion. It does not have standardized criteria. Some of the programs require the students to find their own clinical rotations. The requirement, as I said, is completion of the rotation. It is not metrics to meet. I've shared the story of my first day of practice with some of you. It was many years ago, but I remember the day as though it were yesterday. I met an elderly patient who had a life-threatening issue. I was able to collaborate with my partner to provide my patient with the care needed for successful treatment and recovery. Concerns regarding prescriptive writing is a national issue and has been addressed as well today. Physicians and nurse practitioners have full prescriptive authority, including controlled substances. Physicians are regulated under the Medical Licensing Board. Nurse practitioners report to the Nursing Board. There is no statutory requirement that nursing boards have members with prescriptive authority. The Medical Licensing Board has established rigid requirements for prescriptive authority, and this should be the medium for those who prescribe. I'd like to focus the remainder of my testimony on safety, both for patients and for non-physician healthcare providers. As it's been discussed since we started our conversations earlier, team care has been shown to lead to better patient outcomes. Collaboration with our highly educated healthcare providers, nurse practitioners, physician assistants, pharmacists, physical therapists, occupational therapists, and registered dietitians allows the team to provide comprehensive care for our patients. There was conversation regarding concerns regarding areas in Indiana that lack healthcare providers. This is a real problem and we do need to address it. Under the current collaborative agreement, a physician does not need to be on site. Rather, it requires that a physician be available in the event a case is complex and the nurse practitioner needs assistance. The current law permits nurse practitioners to practice in underserved areas. So there isn't a need to change the law to expand geographic opportunities. An area that does have opportunity for improvement include chart reviews. Discussing the process of chart review and costs associated with chart reviews to make this more valuable would definitely be beneficial for nurse practitioners. Certainly after a time period, chart review becomes less helpful. It is in this area that adjustments could be beneficial. In summary, we're concerned about complex medical situations that independent nurse practitioner practice could leave both the patient and the nurse practitioner in a situation that is difficult to maneuver. Permitting independent practice after 1 year of collaboration is absolutely inadequate. Lastly, granting collaborator status to another advanced practice nurse practitioner as proposed in this bill, is not appropriate. We are in support of continued improved collaboration with adjustments and eventual elimination of chart review with experience. Thank you.
Thank you, Dr. Wenk. Dr. Feldman, I did not ask you to be on deck. I'm so sorry about that, but Richard Feldman, former health commissioner and advocate from Indiana Academy of Family Physicians. And on deck, we will have, I'm sorry if I can't pronounce this name, Mukhtar. Did I pronounce it properly? From the State Medical Student Society. Sorry. Dr. Feldman.
Madam Chair and members of the committee, thank you for the privilege of speaking. I'm Richard Feldman. I'm a family physician, former Indiana State Health Commissioner, and I represent the Indiana Academy of Family Physicians as their chairman of governmental affairs and legislation. The Indiana Academy of Family Physicians are opposed to independent APRN practice as outlined in House Bill 1097. But we clearly consider APRNs colleagues and value their participation and relationships with physicians. We have long believed that they should be part of the healthcare team led by physicians. In this relationship with the physicians, they are valuable to the delivery and the expansion of healthcare services, especially primary care. As State Health Commissioner, I actively supported the creation and maintenance of nurse-managed clinics in underserved areas of this state. They work quite well in collaboration agreements with physicians. I take no pleasure in being here today to oppose independent practice, but I feel compelled to do so. And for the medical community, I truly believe this is not about turf. It's not about competition, but quality and safety of care. There are certainly many talented and capable APRNs, especially those who have practiced for many years. But any physician who has trained or worked with a nurse practitioner knows that they have limitations due to limited training and experience. As a residency director in family medicine for the past 37 years, I have trained not only family medicine residents, but medical students, APRNs, and PAs. And I'm here to tell you there's a huge difference in knowledge, experience, and training between a physician and an APRN, especially as a new graduate. The central issue here is the quantitative and the qualitative aspects to training in pharmacology and clinical medicine. Training is far from equivalent, as you've heard. You've already heard that there's the disparity in the training hours from a physician compared to an APRN. Physicians train somewhere between, and it varies, 12,000 to up, I've seen 21,000 hours, as compared to 750 or 1,000 hours of clinical experience for APRNs. And their training pathways, and I think you've heard this today, lacks consistency in their training, and clinical exposure varies greatly from school to school. But very importantly, there's the qualitative difference in the training of a physician that involves intensive experiences, depth of responsibility, and intervention, and years of direct, shoulder-to-shoulder, on-site supervision and oversight by faculty through the clinical years of medical school and residency. 5% chart audits are not equivalent or a substitute for supervision, direct teaching, and mentoring. Patients come to a physician or an APRN undifferentiated. A chest pain could be a heart attack. It could be a dissecting thoracic aortic aneurysm, or it could be indigestion. Back pain could be a lumbar disc, or a kidney stone, or a leaking abdominal aortic aneurysm, or maybe prostate cancer. APRNs need to be prepared to encounter all such clinical situations. There is a danger not in recognizing what one does not know through inadequate training and experience. And there's always going to be subtleties and complexities that demand a physician's clinical experience and judgment. APRNs claim that they are, when they're faced with more severe or serious disease, beyond their capabilities, they'll naturally refer to a physician for care. And I'm sure that they would. But they have to reliably recognize the situation first. I doubt that any of you would want to go to a physician who graduated medical school and then went out into independent practice after completing simply a 1-year collaboration agreement for 5% chart audits. Potentially with a practitioner at a distant site from the nurse practitioner, as suggested in this bill. I hope the same would be true for an APRN in independent practice. As a residency director, I can attest to the readiness and competence of a resident for independent practice after 3 years of intensive on-site direct supervision. And I actually must attest to that in writing before they can graduate residency by accreditation rules. Having said this, the Indiana Academy of Family Physicians has made it clear that we're willing to compromise with the APRNs in their pursuit of independent practice. But there was really relatively little willingness to compromise last year. And the Indiana Academy of Family Physicians has really not heard anything. We have not been approached this session. I do not believe that the requirement of a one-year chart audit collaboration, especially with not even a requirement for a physician, can assure the readiness or competence for independent practice. And we really need to look at this 1 year. What's 1 year? A year in a physician's life, work life, is probably 3,000 hours. And if I remember from our discussions last year, and I may be wrong, but it was 1,200 hours is a year of clinical practice. I'm not sure I understand that. I may be wrong. I'm sorry if I'm wrong. But we need to define what 1 year is. The compromise position of the Indiana Academy of Family Physicians offered last session and rejected was that if an APRN desires independent practice, the APRN would work directly for 3 years, which in my world would be 6,000 hours of a normal work week, with a physician or in a licensed facility with direct, on-site, shoulder-to-shoulder supervision. The APRN would then apply to the board for independent prescribing practice, but with a consulting physician relationship. And that consulting physician should have indemnity for liability. This is not physician oversight, but consultation and advice when needed and appropriate and requested by the APRN. This could take also the form of a patient transfer agreement to a physician or facility if the consultation concept is not feasible. APRNs are worthy professionals and essential to patient care, but they are not physicians. Our issue at the Indiana Academy of Family Physicians is not so much about opposing independent practice, but providing more adequate training and experience before independent practice. We stand opposed. I would just like, very briefly, I found a quote from a family doctor that underscores what I've been trying to tell you. I didn't know what I didn't know until I went through 7 years more training, says family physician LaDonna Schmidt of Salina, Kansas. Schmidt was a nurse practitioner before she did training to become a physician. Schmidt noted that she thought that her further training to become a doctor would be easy because she had already gone through the training to be a nurse practitioner. It wasn't until she got into the program where she realized how much she did not know. Thank you very much for the opportunity to speak.
Thank you, Dr. Feldman. And you'll have to help me with your name. Is it Mukhtar? Sure. Okay.
Mohsen Mukhtar. So, Madam Chair and members of the committee, thank you so much for your time. My name is Mohsen Mukhtar, and I'm a fourth-year medical student at the IU School of Medicine on behalf of the Indiana State Medical Association Medical Student Society, here to share a medical student's perspective on this proposed legislation and, in short, why we stand in opposition to it. I think, as has been discussed already, we've discussed the changes or the various sort of hoops that medical students have to go through in order to be a licensed physician. 4 years undergraduate study, 4 years of medical school, residency and fellowship, what have you. And that stands in stark contrast to the sort of training that may be required for APRNs. And I think if you dig deeper there is a lesson to be learned in that it's not just the adequate knowledge base that you're building, it's the repeated testing that takes place and the extensive sort of feedback that you get over the many thousands of hours of clinical practice from a physician who's been in practice for many years. And that occurs both in clinic and in didactics. And that allows for a reasoned sort of thought out sort of clinical practice once we actually arrive at that final destination of being an independent practitioner. And this sort of bypassing of that traditional pathway is almost calls into question the very system of medical education that we have. in that it suggests that perhaps there is a more efficient, more robust, perhaps even a cheaper pathway to arriving at the same final destination of an independent practitioner. And so we worry as medical students as to whether if that is valid, and in fact, if it is so, perhaps what's wrong with our medical educational system as we have it today. And as medical students, we're also sort of worried about and looking out for the students who will come after us, the students who are high school students or in college right now who are thinking about a career in the healthcare professions. And we feel this sort of legislation does them a disservice in that when they're called to sort of think about the various options that they have, the different career pathways that they can pursue, there are very sort of, there's the traditional MD-DO pathway with its extensive training and testing and very arduous pathway, and then you see this other pathway, perhaps it's cheaper and faster. And I think it does a disservice to the traditional system of medical practice that we have in place, in that it makes that decision a lot more complicated to being an independent practitioner. So with that, I welcome questions as you have.
Thank you. Yes, we'll hold our questions until all. Thank you so much. And Sean Nung, Physician for Patient Protection, thank you for phonetically spelling your name for me. And then on deck, and I'm sorry I didn't advise you to be on deck, I'll give you a few seconds for that. Anne Marie Hyatt from the Academy of Dermatology, you are our last to address the Assembly.
Hi, I'm Dr. Nung. I'm an internal medicine doctor. I'm practicing here in Indiana. And I'm here to discuss why I oppose 1097. And really, I agree with all the physicians ahead of me who've said why this may not be a good idea. But I wanted to address something that someone mentioned, that there was a science that backed that nurses performed like doctors. And I just want you to be aware that the Cochrane study said that that was not true. I can provide you guys with that information. You can look that up. But that the methodology was not as strong as perceived or has said earlier. Also, we're talking about two different fields, so the focus of practice is different. So, of course, what was studied in a lot of these things in terms of their endpoint is not as what a doctor would consider important. Like for us, it's morbidity, mortality. Those are the things we study. As so, what we do, has that helped the patient acquire a better life, a longer life? And what nurses, and I think what their education pushes is, whether someone felt good or not, where they will hold their hand. And the thing is, it's great to make someone feel good, but at the end of the day, I think the research should show that they got better care, period. Not because they thought they got better care, but they got better care. So it would be a disservice to offer care that's not being supervised to rural counties just because we have a great need right now. To be honest, there are 9,000 medical doctors who have passed their steps 1, 2, and 3 who were not able to get a residency position. These are people who've had 3,000 hours of patient clinical care and are not allowed currently to work independently. And to me, that's a group of people that can fill this shortage as well. And something that I'd like to maybe put forth in terms of as another way to also give access to care to rural Indiana. I appreciate it.
Thank you, Doctor. Thank you so much. You. And then Anne Marie Hyatt.
Thank you, Chairperson Kirchhofer, and distinguished members of the committee for this opportunity to provide testimony in opposition to House Bill 1097. I've crossed out almost all of my pages since everyone's already said most of what I was going to say, and my parking meter is up in about 10 minutes. So, but I did want to point out a few other things that I have that I don't think have been said yet. I think this legislation will move away from a goal of delivering healthcare in a coordinated, cost-effective manner and toward a fragmented system that unnecessarily jeopardizes patient safety. And today we rely on a coordinated, team-based approach. I want you to know that I think nurse practitioners are valuable healthcare providers. I work with an intelligent and caring nurse practitioner in my practice. We collaborate on a daily basis. If she's seeing patients, there's a physician on site to see each and every new patient, as well as help with any new problems that may arise. This is a good, safe model for patient care. I know that our nurse practitioner and I would not be comfortable with her practicing dermatology on her own. She is invaluable to our team, but she is not a dermatologist, and there's a difference in knowledge and thus patient care. The collaborative model has overwhelming support from the public. According to 3 nationwide surveys conducted between 2008 and 2018, 84% of respondents prefer a physician to have primary responsibility for their diagnosis and management of their health care, and 91% of respondents said that a physician's years of medical training are vital to optimal patient care, especially in the event of a complication or medical emergency. It's also important to point out that 89% of nurse practitioners are trained in primary care. They are not trained in specialty care, and this bill would not restrict them to practicing within a primary care field. 1 year of collaboration with 5% chart review requirement as proposed in HB 1097 is not nearly long enough to ensure a nurse practitioner is competent to practice independently. This bill would also allow a nurse practitioner to change their field of practice at any time without adequate training and supervision within that new area of medicine. So allowing nurse practitioners to independently practice would afford nurses the same authority and clinical autonomy that physicians have without the education and training that our state currently requires of physicians. This is why the safest, most effective way to provide quality care for Hoosiers is to continue to utilize our nurse practitioners and other extenders as part of the physician-led health team. This means retaining the requirement of collaborative agreements. I'm very concerned House Bill 1097 will significantly undermine the delivery of quality patient care that Indiana patients deserve. For these reasons, the Indiana Academy of Dermatology urges members of the Indiana House Public Health Committee to oppose House Bill 1097.
Thank you, Doctor.
Thank you.
Questions for any of the physicians or physician groups? Representative Hatfield. Dr. Feldman?
Yes, Representative Hatfield.
Thank you, Doc. I don't want to go down a rabbit hole here, but you did say something that piqued my interest, and I'm just interested in your response. The collaborating agreements that we've been hearing about and the argument for keeping them is that the training expertise of the nurse practitioner is not sufficient. Doctors have superior training and expertise. You mentioned that it was important to keep the consultation available, but to provide indemnity to doctors. Could you square that for me, why a doctor deserves indemnity if the expertise is so important for him to be there, him or her?
It would be several reasons. One, it would probably be very difficult or impossible for a APRN to find a consulting physician without indemnity. Why would a physician want to get into a consultative, not collaboration, but a consultative relationship for advice and consultation without indemnity? Because they're probably safer not entering that type of voluntary relationship.
But if the nurse practitioner is so dependent upon that doctor's consultation, wouldn't it be important then to know in a case where something has gone wrong that it was the doctor's expertise that was so important in that practice?
The doctor's expertise is very important, and it's really just, it's not a requirement. It's just not a requirement to consult. It's when the APRN feels uncomfortable and is unsure of what to do. And they would be available to give advice and consultation to that APRN. So I think it would be, well, I'm going to repeat myself, but it's going to be very difficult to find physicians to do that. I'm not sure I answered your question.
I must have upset someone in the leader's office for somebody to come get me on the floor right now, so I'll leave it there. But I appreciate it. Look, that struck me as interesting, that the argument from the opposition today has been that we are so vital in consulting with these folks because of our expertise, but when our expertise leads to bad decisions, we also are going to demand that we're off the hook.
But you're also looking at a situation where the doctor was not involved in the care. And you're right, there's a difference between collaboration and consultation. And what mess they may be asked to enter may be a factor that would prevent doctors to wanting to get into it in the first place. They weren't involved in the care.
That I certainly understand. Thank you.
Thank you, Dr. Feldman. Any other questions? Representative Bacon?
I've got one it's coming for Dr. Wink.
Oh, sure. Dr. Wink, do you mind?
I'm just trying to clarify some of the things that you said earlier that I was a little confused on. When you mentioned that as far as being able to enter the APN field, the difference in qualifications of the practicing nurses and LPNs, nurses, and so forth out there now. Were you saying that an LPN or a 2 or 3 year associate degree nurse can enter the nurse practitioner program without having a bachelor's degree first? And I'm just trying to clarify that.
Sure. Sure. I think that there's several pieces. Comments that were made earlier were a little bit old data. Many of the nurses who are going on to nurse practitioner school are not bedside nurses. So Dr. Fleming practiced bedside nursing and then went into nurse practitioner school. So she had a lot of exposure before she went. Now the academics in the process is graduation and direct entry into nurse practitioner school. Those different degrees, they can be LPN, RN, they can be a bachelor degree. They don't have to be a bachelor degree. They don't have to take the GRE. There is, I just lost my train of thought and I apologize. It'll come back to me.
What I'm trying to clarify, so you're trying to say then at a nurse that just got out of an LPN accredited school can immediately go into nurse practitioner? With
an undergraduate degree. And then there's also the online courses that are streamlining progression of diplomas as well.
Okay, because I was not aware of that. I figured the requirements were you had to be an RN first. It's with a bachelor's. That was my understanding, and that's why I'm trying to clarify that before you can get into a nurse practitioner program, you have to have. It is
in the RN in the nursing arena. Yes. Right. So a philosopher, right? A philosopher.
So an LPN couldn't. She would have to have an undergraduate degree and have an RN before she could become in the school. Is that correct?
You know what? Let me just double check my facts. Yeah.
Okay. Thank you.
Sorry, Dr. Fleming.
Dr. Wenke, I realize you may not be able to answer this for all of the members of the ISMA.
Sure.
But could you foresee that ARPNs who have passed a certifying exam, who have done the required level of clinical training, clinical education, if they had a collaborative agreement, that doesn't necessarily mean somebody on site looking over their shoulder, but a backup, essentially, for the more complex situations or cases that they're uncertain of. I have backup. I have maternal fetal medicine backup because I'm a generalist. Would you then see ARPNs as being able to practice independently, if you call that independence?
Sure. So that is what's in place right now. The collaboration is the component that's intrusive in our interpretation is the chart review. The second component is the oversight from a prescriptive point of view. The chart review is a retrospective, and we all know as scientists what retrospective provides to us. Following the medical licensing prescriptive requirements and regulations would be a greater comfort because that would then be able to be monitored a little bit closer. So jumping into the independent provider arena, then we jump into the provider arena. 1 year, I don't think that we feel good about that at all.
Dr. Wink, we've heard a lot about patient safety and ensuring the having a safety net for the patient. And do you know, I know I've seen statistics and data on claims.
Sure.
Often there's claims on physician by specialty, but have you seen claims data, physicians versus APRNs?
Sure. And I think that that's a great question, and it wasn't something that I was going to bring up, but the data takes time to gather. So independent practice is in a relatively new arena. CRNAs have 10 years of independent practice. So that data is just now starting to arrive, if you will. So the data that's out there that we've been able to see where there is a very low malpractice rate for nurse practitioners is based on collaborative agreements. So as patients have struggles, etc., we work as a team to be able to stabilize the patients. If a bad outcome occurs, it typically fell to the physician branch of that teamwork. So time will tell. It's a little bit early. The studies are not current to include the independent piece.
Thank you. Thanks. Other questions? Representative Bacon, my step counter is telling me it's time to move. And for the governmental affairs types in the room, the spirit of Senator Miller is alive and well. And with that in mind, Representative Bacon, you are charged with taking the stakeholders to a war room and not emerging until you come back with some resolution.
Yes, I'd be happy to do so. I would like to make one comment, and I'm not sure who asked the question or amended the sentence, but last year we also did in Senate Bill 410, the APRNs are not allowed to switch professions or just, without, just switch over to what they want to be today versus what they want to be tomorrow. So that is not, and we did that in Senate Bill 410 to get you the correct knowledge on that. So I will be happy to go back with the stakeholders and come back, and hopefully we can come back with an amendment that will be plausible for the committee to look forward to and look into. So thank you for your time and appreciate it very much.
That's it for this evening, and we are adjourned.